Okay. Hi everyone. Welcome to an introduction to blood gas analysis, which is pitched at some of the nursing and allied staff here who work in the HDU. I'm joined by Graeme today, one of my colleagues, who's going to help me with the presentation. We're going to have a bit of a conversation about this topic.
Good to be here, Roger.
All right, so let's get stuck into it. So first thing to note is, as you can see here, that there's plenty of things on a typical blood gas printout. So there's a lot of knowledge, and it can get quite confusing. Even really intelligent people can sometimes, not be sure what they're doing. We'll try and keep it in a little bite-sized amount of time that it's easy for you to try and devote some time to it. So we're going to split up this topic into a few different recordings instead of having it all in one go. And hopefully I will encourage you to perhaps go away and just do a bit of self-directed learning, because some of this stuff is a bit esoteric, and you do have to have a bit of chemistry and basic knowledge about various biology. So instead of watching The Bachelorette, maybe you can plug in your earphones and have a little look at the Khan Academy, which is a really good website for learning basic sciences. I've had a quick look at it myself. So
where does that one come from?
The Khan Academy?
Yes.
Yep. Well, that's have you heard of the flipped classroom?
Yes.
Yep. So I think they were the ones that started that. So
Okay.
The history behind it's pretty interesting. So Khan, the guy Khan who started it, was actually recording lectures or tutorials for his niece who lived on the other side of North America, and then so he put them on YouTube, I think, and then it soon grew. There was millions of people watching his tutorials, and so that's where that comes from.
Okay.
But there's some really good stuff in there in the health sciences and biology and things like that. So chemistry, especially around acid base, have a look at that.
Yeah, I tried to teach blood gas interpretation to the obstetric and gynae staff about 18 months ago as part of their Friday afternoon tutorials, and I was directed to the Advanced Life Support blood gas interpretation page, which you can just get on Google. I think it's just look up blood gas and ALS, and it goes through in a very simple way how to look at the numbers and try to make sense of them.
Okay, and for those people who are watching this, the slides associated with this conversation, the Geeky Medics I found is a really short, easy to read summary of this topic as well. And for those who want to delve a bit deeper, learn about some of the more complex stuff, if this gets your interest going, the anesthesia mcq.com website has got some really detailed discussion about various different subtopics.
We love Kerry Brandis.
Yes, and I think most of it are all based on him. So, all right, so what I thought we'd do in this first talk anyway is just try and focus on understanding the physiology, what it means, and have a systematic approach. So that's basically the key to interpreting blood gases. Is you've got to actually understand the physiology, don't you?
Mm-hmm. I mean,
so you've got to know what it means.
Yeah.
Yeah. So there's no shortcuts there, unfortunately. And then you've got to be systematic. So it's quite easy to get sort of confused and jump around. But if you have a system where you go through it systematically, you usually can get a good understanding of what it means in the patient.
And with respect to physiology, it's really remembering that the human body works perfectly or best when the conditions under which it operates are ideal.
Yep.
I think that's really what the physiology is that's important.
So Graeme, I don't know what your system is. This is sort of my rough systems when I get someone hands me a blood gas, or if I ask for one, which is often recovery or patient in HDU or something like that. The first thing I do is just glance through it, see if there's anything life-threatening. I actually have a look at the oxygenation, so I want to know what whether that's appropriate, and then the pH, acid base, and all that sort of stuff. Try and have figure out what's going on there, and then also look at all the other stuff, so the electrolytes, the glucose, the hemoglobin, and all that sort of thing. So
it's usually the way I approach the problem. We do the gas for a reason.
Yep.
Usually we have a suspicion or no idea what's going on. So, but the patient can't be well or must be in a critical situation usually, and then it's from there oxygenation, pH, acid base, and then the other information on the blood gas.
All right, so let's have a look. So is there anything immediately life-threatening? I'll I'll explain what I look at. So when I this is just an example gas, so I look at it, I think there's about 4 things which are immediately life-threatening. Obviously there's some other ones which are potentially life-threatening, but not in the sort of short term. So looking at oxygenation, so if someone's hypoxic, you want to know that straight away. We'll talk about that in a minute, what is an appropriately safe number. Hemoglobin, if the hemoglobin comes back as 10, then that's pretty scary. And the potassium, so any potassium over 6.5, you could cause an arrhythmia. And glucose less than 3, especially if it's really low, like 2 or 1. So all of those 4 things, I just have a quick glance, make sure none of those are really wildly abnormal. Is there anything I've missed, you reckon?
Sometimes I look at pH.
That's true.
Because if it is particularly low, the other numbers sometimes may look normal.
Yep.
And that guides you to what problem you're likely to be facing.
Yep, that's right. So I guess, a pH of 6.7 or something like that is very life-threatening as well. On one other point, so make sure you know whether it's an arterial sample, which most of them are, but not always, or a venous sample when you're looking at the PO2.
Yes.
We might mention that again later. So obviously a venous sample, the PO2 is going to be low, so you pretty much have to ignore it.
Otherwise, most of the other information on a venous blood gas is useful.
That's right. Yep.
For interpretation.
So there's not that much difference. So venous blood gases are almost as useful as an arterial one. All right, oxygenation. So let's have a look at that. So first thing to mention, so some people will know this is a pretty basic concept, and apologies to people who understand this, but some people will get a bit confused about the difference between oxygen saturation, which you get off a pulse oximeter, and you also get on blood gas, and the partial pressure of oxygen. So there's a bit of a difference, isn't there? So one is, I'm going to try and explain this, and Graeme can interrupt if he thinks I'm making a hash of it. But so saturation is basically trying to describe how much oxygen is on the hemoglobin molecules. And obviously, in a normal situation in the artery, you want more than 90%, probably more than around 95% or more of the hemoglobin to have an oxygen attached to it. So that's a pretty simple concept. The partial pressure is actually just a reflection of how many molecules, or what the driving force of the oxygenation is. So that's related to a number of things, including the pressure of the atmosphere, the presence of other gases in the alveolus, and that sort of thing. So they're related but different. Do you think I explained that pretty well, Graeme? I'm not sure I did the pressure one very well. I think the saturation was okay.
I mean, the partial pressure is a hard thing to describe eloquently.
Yes, that's right.
I think the thing to remember is roughly the oxygen saturation will be 90% and greater, usually, where the partial pressure of oxygen is 60 millimetres of mercury or greater.
You're preempting me, Graeme. So let's move on to the next. But I do. So that's a good point.
Perhaps the other thing we should say is that usually the total pressure in a system at sea level is about 760 millimetres of mercury.
Yep.
And what that reflects is that the partial pressure of oxygen is about 1/8 of that, in order for the oxygen saturation to be 100%.
We've already mentioned venous blood gases. Everything. So just be careful. You can't really assess this in a venous blood gas. So we're going to get on to all the points that Graeme has raised. Here we go. So this is the physiology. So what you've got to remember is that we're looking at the cascade of oxygen. So there's oxygen in the atmosphere. See the numbers here represent the millimetres of mercury pressure of oxygen. And it goes through various stages as it passes through the human body. Now, when we're looking at blood gases, we're only assessing a small part of this oxygen cascade. But you can see that it's 160 millimetres of mercury in the atmosphere at sea level. Gets a bit of water gets involved, humidifies the gases as it goes down our nasopharynx into the lungs. So the pressure drops a little bit there. And then it gets diluted by carbon dioxide and other things down in the alveolus. So the pressure of oxygen in the alveolus is about 105. There's a little bit of shunt. So that the gas in arterial blood is actually just a little bit less than that. So a person who's breathing at a normal rate and room air at sea level normally has approximately 100 millimetres of mercury as a PO2.
And shunt is blood that passes from the right side of the heart to the left side of the heart without any gas exchange.
Yeah, that's right. So it's basically a little bit of venous blood. It goes through the lungs and it just stays venous. So it's got a bit more deoxygenated hemoglobin, and it just dilutes things a little bit. And we could probably discuss that in more detail somewhere else.
It is normal to have some shunt.
Yeah, so there's always a little bit of shunt. So that's pretty much what we're looking at. So that's basically what we're looking at the blood gas for. Is we're trying to assess, has this sort of process that I've circled with the red circle oval, is this process working appropriately when we're looking at our arterial blood gas?
I just went on a holiday, Roger, to the Dead Sea. It's
Yep.
420 metres below sea level.
So,
and the partial pressure of oxygen is 8% higher there.
yep, that's very interesting. And so I don't think we're going to have any listeners from anywhere at altitude, but the places that are often quoted when I've been talking about this subject, Colorado and Johannesburg in South Africa, so some of those big cities are actually quite significant altitude, and so that is going to affect your PO2. And obviously everyone talks about what's your PO2 on Everest, so that's very interesting if anyone wants to Google that and gets excited by this topic. So Graeme's already answered this question. So what is a safe PaO2? So yeah, the rough rule of thumb is have a look at the PaO2, and if it's greater than 60, that's probably safe. And why is that? So let's have a little look. So this is going to bamboozle you with a bit more physiology. So this is a curve that describes how hemoglobin binds and releases oxygen. And so when the hemoglobin is going through the lungs and picking up oxygen, there needs to be an appropriately high pressure of oxygen or gradient in order for most of the hemoglobin, or a safe level of hemoglobin, to be saturated above 90%. So I've drawn a little line there. So you can see at 60 millimetres of mercury, at least 90% of the hemoglobin will become saturated or will bind oxygen. So that's the sort of sweet spot. So obviously if someone's at sea level, breathing room air, and their PaO2 is only 60, that's abnormal, but it's still safe. So it's not saying there's nothing wrong, but it is safe. So that's what you're looking at. All right, this is where it gets a bit more complicated, but what about if they're on oxygen, Graeme? That makes things a bit confusing, doesn't it? How do we know if they've got good gas exchange? If someone's got some breathing problems and we give them some oxygen, because not everyone's breathing room air, are they? Especially our HDU patients, our patients in recovery, they all have oxygen on.
They do. I just want to go back a little bit. It can be safe for the PaO2, the partial pressure of oxygen, to be 60, but it should be something to alert you that the patient's quite vulnerable to getting unwell.
That's right. So they're right on the edge,
quickly,
aren't they?
They are.
So if anything else happens, they stop breathing a bit more, they get a bit more drowsy, or they have a bit more obstruction, or the oxygen mask comes off if they're on oxygen.
Yep.
Then they're not very far away from to life-threatening hypoxia, are they? So that's an important point.
Yeah, there's not much reserve at that point. In terms of the next question, what if they are on oxygen? How do we know if they have good gas exchange? Well, partly we can tell by doing we can look at the patient. That's one thing. If they're a blue colour, that's not a good sign. And we can also look at the blood gas results and look at the PaO2 and see what that shows. If it is low, we can use the ideal alveolar gas equation to...
So I might just interrupt you there because I don't think people need to know this.
No.
But I'm just going to mention it because people will probably come across it if they're trying to do a bit of their own self-learning on the internet. So there is an equation which can help you sort of ascertain, if you know how much oxygen people are breathing, you can do a bit of a calculation and plug these numbers in and figure out what the blood gas should show. But we're not going to go through that. But if someone wanted to learn that, they could teach themselves that on the internet. But what I just want the principle of people to know is that when you're looking at a blood gas, you should know what's wrong with. You should know your patient. So this is a patient who's pretty happy. She's obviously breathing room air. We can't see any oxygen therapy on her, and she has a PO2 of 98. This is not a completely normal gas, but let's just focus on the O2. PO2 of 98 on someone breathing room air. It's pretty normal, isn't it?
It is.
So that's good. What about this woman? She's got a reservoir mask on. It's tightly fitting. she's actually breathing somewhere between 60 to 90% oxygen, and her PO2 is 98. Obviously, I'm just making this up. I'm using the same gas, but
that's a low PaO2.
The first patient, we're thinking she probably doesn't have anything wrong with her lungs, nothing serious. This woman here, a PO2 of 98, when you're breathing almost 60 to 90% of oxygen, she must have something really serious going on.
She's either got significant respiratory disease, significant heart disease with a shunt.
That's right. So she's got something causing a blockage of gas exchange. So the oxygen is not getting from her her respiratory tract into her bloodstream. So something's going on. So that's a really bad sign. So the point I'm making, I guess, is that you need to involve the patient and the clinical history. And this is just a little bit of a rough thing I found to sort of for people with a rough rule of thumb. When you're trying to assess how much oxygen someone's breathing, you can have a look at that yourself. Pause the talk or look at it. But basically, you can see that for the common things like nasal cannula or Venturi masks, you can't really get above 40 to 45% oxygen. But with a reservoir mask, which is tightly fitting, you can get at 60 to 90%. So that's just making that point again. So, and then the next table. So this is a table which gives you a rough estimate of what your PaO2. So the numbers on the right hand side are what you should expect your PO2 from your blood gas to show if they are breathing a certain amount of oxygen. So the woman with the reservoir mask should have had a PO2 of somewhere between 370 and 590, and she was only 98. Yes. So that's just telling us that there's something bad wrong with her. Now the truth is, you probably know that just by looking at the patient. She'll be struggling to breathe. She might have pulmonary edema or severe asthma or pneumonia or something like that, and there'll be lots of other signs, not just the blood gas. And this woman here we go. So this is the final thing I was going to talk about, oxygenation. So there's sometimes people talk about type 1 and type 2 respiratory failure, which I really don't like because I can never remember. Can you?
I can remember some odd numbers, like I think the PaO2 less than just 50.
Yeah, so it's just
and
a classification.
And the PaCO2 over 50.
Yeah, so like basically, so type 1 and type 2, you have to be hypoxic.
Yeah,
so it's talking about and then one of them, the CO2 is high, so you're not ventilating much, or the CO2 is normal. And so this blood gas here, this is the CO2 is through the roof, and she's also hypoxic, severely hypoxic. So she would be a type 2 respiratory failure.
Yes.
I think probably the truth is it's hard for us to remember these. The best thing is to just describe what you see. So a hypoxic patient with a high PCO2, she's got ventilatory failure. So there's a whole heap of reasons why that can occur. Some people describe that as respiratory acidosis, another way of describing it, isn't it?
I mean, they can be mixed.
Yeah. So we'll talk about that in the next discussion. So that's pretty much where I wanted to stop. So take-home points for the first part of this discussion. You've got to learn. You do have to learn or understand a bit of physiology. We haven't even got into acid base yet. We'll do that in the next one. But the first thing you should probably do when you're looking at blood gas is check for the life-threatening things, and then assess the oxygenation. Any comments,
No,
Graeme?
perfect.
Good.